Okay, good afternoon, I guess. I'm in Texas, so I'm on a different time zone. Um, I am going to share my slides in a second, but I just wanted to introduce myself first. I am Maria Monge. I am an adolescent medicine fellowship trained internal medicine pediatrics, like boarded physician. Um, all that means is I went to way too much school. And now the sweet spot of patients that I see is kind of in the 13 to about 30-year age range. And often I'm asked why in the world I would do such a thing. Some days I'm not sure that I know the answer, but honestly, I love adolescents. I think that the potential that they have is just pretty incredible, actually. And the fact that they're brains haven't fully developed and are still evolving to make different choices, perhaps, than what adults make, is really kind of a unique opportunity for me to feel like I am able to kind of affect their future. So I am an associate professor of pediatrics medicine, medical education at Dell Medical School at the University of Texas in Austin, and do a lot of work in advocacy, specifically around marginalized populations. And so I like to say, and you probably can all appreciate this, that my presentation today is my own. I'm not speaking on behalf of the University of Texas, nor would I ever try to do so. So just to make sure that you all know that before we start. I also have a fairly, I think, informal presentation style, meaning that if you have a question, I will try to get to it as we're going so that it's top of mind versus trying to come back. So please feel free. And my presentation is modifiable by me as we're going through. So I'm certainly not wedded to anything in here. So if you do feel like we need to stop and discuss something, by all means. All right, and now is like the moment that of truth, right? Is when you're trying to share your screen. And I think my guess is I'm on the wrong one though. Do you see the presenter view? Yeah. Okay. And now you should see.
Beautiful.
Okay. All right, very good. So again, this is me, and here are all of your disclaimer slides from HRSA and HHS that I believe you see every time that you have a presentation from ECHO, and its support. Is not. Again, I also am not speaking on behalf of the government nor any of its entities, the federal government. So, and here you have the mission of the ATC program. I participate in an ECHO down here in the Texas area, which has been really helpful, and a lot of folks have benefited from it. So I'm very familiar with what you all are doing. And then the vision of transforming HIV care. I must say that I was just talking to pediatric residents this week on Monday, and was sharing my excitement about how it really does feel to me like we're kind of on a precipice of getting ready to have HIV as essentially what would be a vaccine preventable illness, which has a whole other set of implications right now at this moment in history. However, I remember when I was in fellowship actually participating in an HIV vaccine trial. That didn't go anywhere. I'm not even sure I think I got placebo actually. I don't have any idea what that was, but that's not what we're seeing now. But we're really the long acting PrEP is it's just so exciting. I think everything is getting ready to just become better for folks. So it's great to be here. I always say that I'm looking for disclosures, but I have none. So if anyone does, I'm happy to entertain them. I also have a couple of pictures, but I try to take my pictures almost exclusively in any presentation from the Adolescent Health Initiative, where they actually specifically took pictures so that people across the country and across the world could use authentic, realistic pictures of adolescents in their presentations. All right, so today we're going to cover the application of adolescent development principles to HIV prevention, strategies for prevention services that are adolescent friendly. We will briefly review eligibility criteria for PrEP in adolescents, which isn't a lot different than in adults, but some notable things. Look at some updates, and then finally really try to give you some techniques to understand the barriers that adolescents do have in this moment in history, and also because of their just global development, and trying to keep them as healthy as we can. So I'm going to start with a fairly typical case, and if I'm being honest, this is a little bit of a amalgamation of a couple of different patients that I've taken care of, but I think it demonstrates some different points quite nicely. So this patient is Jordan, who is coming in to your health center for a well-visited check-in before their junior year in high school. Jordan's been coming into clinic for the past 8 years and is a pretty reliable patient in terms of showing up for his visits. Generally healthy, he doesn't have any chronic conditions, he lives with a supportive single mom. His biggest thing that he's so excited to share with you is that he is active in school theater. And it's kind of like what I don't know if any of y'all were theater people, but if you're a theater person, that's what you do always, all the time. And so, especially for high schoolers, so he is there a lot. In the course of your visit, you find out that he became sexually active 6 months ago and has had 2 different partners of different genders. He, like so many of my patients over the years, usually uses condoms. What that means is up for debate. And you can get him to say, right, that means not 100% of the time. Currently, the partner that he has is resistant to him using condoms. And he's never been tested for HIV or STIs. And he has no idea about his partner's HIV status. Frankly, this feels like a foreign language as you're talking to him, and wants you to know that he's pretty sure he's okay, though. So really, you shouldn't worry. So let's stop for just a second, and I want you to think, and you can share if you would like. And I was looking for the chat in case someone's in there. Sorry. Technical challenges, got it. So please feel free to share if you would like, but what are you thinking immediately when you hear about this 17-year-old involved patient who comes in for just kind of routine care, is sexually active, not using condoms, like, but he's fine, he says he's fine, like, I don't know why you're worried. So what would you say? Like, what do you say next? And then what are you going to do? So this is kind of such a typical scenario that plays out when you're treating adolescents and young people, that I think it's going to be helpful, hopefully, to go through this and kind of think, what would I do? How would I address this? What would I say to him so that he leaves, even if you don't screen for HIV, even if he doesn't leave with a PrEP prescription. I will say that I like to put things into the universe, and I say this all of the time. Sometimes on first introduction, young people are like, yeah, you adults, whatever. And the next time may be the time, or the 3rd time, the 5th time, the 10th time. Lynn notes in the chat that sorry, I'm assuming pronouns. She's impressed that there's a comfort with talking about sexual health, and he should be thanked. And I totally agree. And I have 2 comments to that I think are really important here. One is that Jordan has this long-term relationship with the clinic and probably with the provider as well. That then has created this sense of comfort that most teenagers, if they have been coming there for a long time and seeing a similar person from familiar faith, they will share a lot of things. Like, and sometimes you think, I'm not sure I actually need to know that piece of the information to help you with your health, but thank you for sharing. Um, and the rapport that Aaron points out is like, yes, that is where the trust, that is where them saying, okay, if this person recommends that maybe I consider preventing HIV, maybe that is something I should really consider for myself. So now, the flip side of that is you may have a situation where you're encountering a young person in a sexual health clinic. And so they are specifically coming to the clinic. And therefore, it wouldn't surprise me that they are a little bit more open with kind of what is happening from a sexual risk-taking behavior standpoint. So lots of things to think about in terms of how do we just get them to say how we can help them, frankly, or what would benefit their health. And Anthony notes that really trying to explore with him why he thinks he's okay, starting to build up that rapport. And I would say you all in this line of work, motivational interviewing is like what you do on the daily, right? Like every patient probably feels like a motivational interview. Adolescents are no different. They also respond well to especially covert motivational interviewing and kind of trying to get to the where you need them to be to understand their risks. And Zanetta notes that just assuming that all partners are potentially, are HIV positive, so you wouldn't have to really think about considering if you trust them, if you love them, like those are not considered in the HIV status question. Instead, it's just this is how we think about it. And we'll get to some of these for sure. Thank you for sharing. So this slide is probably not going to be a big surprise to any of you because at this point in your life, you've seen a teenager. You were a teenager, and perhaps you remember that teenager decision making is not the same as adult decision making. We do know that adolescent and young adult brain development happens until the mid-20s and even maybe up until the early 30s. So for many of you young folks on this call, lots of opportunities to still learn and grow and new things. So brain development, you really have the prefrontal cortex that's developing until the mid-20s, and that is kind of your stop point, like that's your check. So I say a lot of times that adolescents don't lack the knowledge. So while I have this context with folks in terms of substances, often they'll say, well, they just don't know better. And I'm like, time out. You can't tell me that 99% of young people don't know that there's a risk to drinking alcohol, vaping, using cocaine, whatever they can. Of course, they know that there's a risk because they've learned about this forever. What they don't have is the ability to then, in that situation, apply that there's a risk and then have it modify their behavior. So that's the prefrontal cortex, is kind of that like decision making. The heightened reward sensitivity is the immediate gratification is really kind of on the forefront. And even adults struggle with having a delayed gratification or doing something now that could affect me in 10 years. And impulse control is still maturing. That's a little bit with the prefrontal cortex. So decisions that people may later regret, or if they had a lot of time to make a decision, they would make a different decision. So that's kind of where we have to keep in mind that most of our young people are very smart. They're very smart. They understand the risks. It's just that getting them to understand how those risks apply to them. And that's what we're going to talk about here shortly. And so the other thing, so peer influence, and this is also very important, right? Who's surrounding but what I want to say is that HIV prevention for adolescents is much more than just medication. Not that it's not that more in adults as well, but the developmental support that you need in an adolescent and the language is just a little bit different than in adults. Their motivations in life look different. Their future plans, their thoughts about future are all very different. And so how you're doing this is just going to be slightly modified from maybe an approach you would take with some of your adult patients in the same scenario. Okay, so I go back to one of the comments just a little bit ago that indicated, we need to explore more appropriately why this patient doesn't think that he has risk. And I like to call this magical thinking, right? So there's adolescent magical thinking that is very, very normal. Like it is a normal developmental stage. And that's going to look like and sound like in your presence, I'm fine. It can't happen to me. Yeah, I know my partners. Like, my favorite. I can tell. I can tell if someone has HIV, like, or I can tell if someone is X, Y, or Z. I hear this a lot, and it's also this like personal. It's kind of like the personal fable, which is I'm unique. Like nobody else has this ability, but I do. And again, this isn't a pathologic issue. I mean, it's perhaps pathologic if it persists well into adulthood and folks aren't maturing beyond that. But in every facet of adolescent care, I hear this. It's like, yeah, but not me. Or, but my condition is unlike all of the other million people that have it. So just kind of understanding that that's how they're viewing the world can be really helpful. They also don't have like experience with consequences in the same way that adults do. So especially when we're thinking about HIV prevention, well, and a lot of adults too haven't actually seen people with really advanced HIV AIDS. They haven't seen folks die from it in all likelihood, right? Because we're at a different place in history. Adolescents really haven't seen it. So some of this, some of the, well, we could use also adolescents don't respond well to scaring. They're like, yeah. We go back to the magical thinking. They're like, but it doesn't apply to me. I hear that, and maybe other people would like be scared by this, but it doesn't apply to me. So this down here, I think is kind of what Anthony and Zanetta were, and I might have pronounced her name wrong, were kind of alluding to. And you're not really arguing against the magical thinking. You're not saying, but you're wrong. You actually are at risk. Instead, it's a very normalizing way to think about things. It's, you know what? I encourage everybody who's sexually active to do this. This is what I do. This is how I counsel people to approach. And so I personally like this strategy if we're talking about HIV screening. And that is, and I've used this technique a lot, and it's interesting the questions that it brings up too, which is, and a lot of you probably do this, when was your last HIV test? Not have you had one? Do you want to be tested? Like, what do you know about it? It's like, hi, Jordan, when was your, I mean, not the first thing I say, but when was your last HIV test? And so often they're like, huh? Like, oh yeah, you didn't realize. And here's what we also have going for us. And that is that at this point in time, the USPSTF, the US Preventative Task Force, does recommend that all adolescents be screened at least once, independent of if they're sexually active or not. Starting at the age of 13, somewhere between 13 and 18, they should have at least one negative HIV test. If they're sexually active, it's recommended every year. So I have guidelines behind me that's like, oh yeah, of course. Everett, you didn't realize that? I am so glad you came so that we can learn together. Yes, everyone, once a year, it's recommended that you have an HIV test. Like, oh, like, so today? So it's like, yeah, so now we're going to do this. Okay. Of course, it's not, we'll get to this a little bit later, it's not quite that simple if we're thinking about confidentiality and other things, right? Because if people are minors in some states, you can't actually consent to anything confidentially anymore. And so agreeing to an HIV test, especially if someone thinks they're at risk for HIV due to their sexual health or perhaps other behaviors, then that is a different story than kind of the we screen everybody. And I have used the actually in a multidisciplinary clinic that I used to run, we just flat out told everybody that at least at once a year, I don't know, one time at least, everyone needed an HIV test independent. And that was our clinic practice. People could, of course, opt out of that, but once we made it our clinic practice and aligning with federal, like kind of USPSTF guidelines, we had much less in terms of, well, why would my kid need that? They're not at risk. What are you saying about my kid? No, it was much more like, we do this for everybody. We just need to make sure that there's nothing that we don't need to be taking care of. That then did eliminate some of the confidentiality concerns because it was a clinic-wide policy. But again, as I was saying, we're in a little bit of a different time in history right now, and that is that confidentiality is just, we'll talk about, but it's not quite what it has been in the past, I think, for some adolescents. So the, excuse me, these are all just like the normalizing, and I'm hoping maybe some of these phrases or these things are resonating with you that you could use at other points and get you caught up on sexual health screening, like, let's just do this kind of thing versus do you want to? The adolescent medicine perspective on do you want to? That question comes with the implied, then that means I have to actually face the fact that I might be at risk. And that is like something that a lot of people don't want to, they're still living in their magical thinking. So if they want to do something, that's acknowledging that maybe that they are at risk, which is why I try really hard in this space to not use a lot of wants and not use a lot of kind of, what do you think about that today? Or do you want to do that today? I will usually say, so how are you feeling about having that test today? Or things along those lines, as opposed to wanting. And it's subtle, right? These are just like so subtle language things that you might not, but make a huge difference.
You have a comment in the chat, and it says the idea of standardizing testing is a great strategy. I work in Virginia, so our patient can consent at age 13 to testing.
Oh, Anthony, you are what's the envy of those of us that don't work in states that have consent at 13. So that's great. And I really have found that to be effective. And interestingly, the chlamydia screening, the STI screening, we also kind of adopted a clinic-wide policy around it that made it so much easier to actually adhere to guidelines around STI screening, and especially when it was urine. So I would encourage you to think through those for your clinics. So why this matters, probably not unfamiliar to a lot of you, but people under the age of 35, again, so just now fully developing brains, they are the ones that account for over half of new HIV diagnoses. And I am really, really hoping that we continue to get accurate data. I am not sure yet. So unfortunately, this data is 5 years old, but I can't imagine that the trends have changed a lot. I'm in the South, and we have a huge like discrepancy in terms of new diagnoses here. Sexual health is not as discussed in the South kind of routinely, and so I envy my colleagues in Boston. I trained in Boston, and I just remember the days of it was just, well, we did, everybody did this, and that's not necessarily the case in the South. So pediatricians, primary care providers, people who see adolescents are really like kind of in that spot of where effective HIV prevention can happen. We don't have to wait for our patients and our young people to seek it out. We can be suggesting, we can be, again, putting things into the universe, as I mentioned earlier. So Trudy in the chat mentions that when an individual tested positive, they were referred to the in-house program to help with the realization of the diagnosis. Yes, I will say that also as an adolescent provider, two thoughts about that are really important. One is now with the immediate release of results in some places, some people haven't turned off HIV as being something that you would hold back from immediate lab release. A young person could potentially see their results really quickly. And if it were positive, even if it's just the first go around and you still have to do all your confirmatory testing, that's a huge diagnosis, right, for anybody to see if they don't have good support. So what I recommend if you are doing screening and testing is that someone in clinic or in your space really be designated as the adolescent, young adult positive test person, right? That kind of understands the nuances of the test, that understands the adolescent brain and what it's thinking and all of the things around it, so that you can do that pretty immediate, even if you don't keep treatment in-house. The immediate kind of aftermath of a positive test looks very different in a 16-year-old than it does in a 26 or a 36-year-old. So having somebody, if you are going to do testing, which I think everyone should be, and you see those young people, to make sure that someone does have that kind of knowledge to address it with them. Thank you for bringing that up. So in our adolescent world, a lot of times we have been victim of our own success almost, which is we get people, we're like, yes, we are so good. We've gotten them educated about this contraceptive method, for example. And then we kind of forget all the other good things that we've been doing. So in this HIV prevention space, we have to be very, very careful that it's not PrEP or condoms, it's PrEP and condoms, or condoms and PrEP. And I realize I'm preaching to the choir a little bit here. I will fully admit that I get so excited about actually like using knowledge, and this teenager listening and they're making really good beneficial health decisions. And then I forget like the really other important things that I'm supposed to be telling them also. So I like to just make sure anytime I'm talking about this to not forget about condom use. I like to ask about condom use, not in do you use condoms or how often do you use condoms. And this is similar for other health behaviors. I say, so I recommend condoms for everybody. In the last 10 times you've had sex, how many times do you think you've used a condom? I don't leave it there. I start with some numbers. I say 2, 5, 7. I don't say 10. I don't say 10 out of 10. But what I've done, right, and what adolescents respond really well to, and frankly, all humans, is norming that they could say 2 because they've heard me say it, right? So 2 is an acceptable answer. 5 is an acceptable answer. They could say, oh no, 100% of the time, but they have to initiate that answer versus you asking, do you always use condoms? They want to make you, like, they want to impress you. They want to please you. You're the adult, you're the authority figure. They're going to say yes, even if that's not golden tickets. Is that condoms, Trudy? So I am that's where I like to start with these questions around condoms for HIV prevention. And some of the reasons that adolescents struggle with condom use are not necessarily the same that adults do. So, but some of them are similar, right? So negotiation skills, partner resistant access, interruption, and the moment. These are all kind of things that could happen to any of them, but adolescents aren't very good. Again, let's go back to the magical thinking, right? And they're like, oh, this one time won't matter. But that one time right there, if they don't also understand additive risk. And so it's like every single time would be different, this like the same zero risk, and that's not good. I also tell people this is not a time that we're looking for a B plus. Like this is a time where we really want an A plus, right? So this is one of those like 100% things. So let's think about how we can get you there. Then the effective messaging, and you know, I think that a lot of us have probably heard the theory that some of our or STI rates have gone up since HIV has become such a treatable condition. And I would say that that's some of it. I don't know that that explains all of it, but I do hear that in patients. I do hear, well, yeah, but I can treat these things. Y'all, as an aside, possibly the most awful diagnosis that an adolescent or young person can get is herpes. I've never seen so many tears than I have over herpes, and this isn't a judgment. This is like so interesting because it's not necessarily what I would consider to be the thing that teenagers would get so upset about, but it is much more so than gonorrhea, much more so than syphilis. And so it's just interesting the perception of what they think are the most risky or the most kind of taboo diagnoses to have. That's just a total aside for your information. But I do like that, like both are better than just one. Like you have seatbelts in your cars and an airbag, because if one doesn't work, you have the other one. So that kind of dual protection, I think messaging is really good for adolescents also. All right. So if we're thinking specifically about PrEP, this is what excuse me, adolescents will say. You can read kind of what we've all heard. And, it's interesting because some of this you would think is outdated thinking with so much of the prevention messaging that we've done. You would think that we're past this point, but we're not. And so only gay people need PrEP. Yes, that happens a lot. Like I hear that a lot. I'm like, that is so interesting. And so I say that phrase a lot if you haven't noticed. Excuse me. And that is so interesting. I'm so glad you told me that. And because that way it welcomes a little bit more. Like, tell me more about why you think that only gay people, need PrEP. And then we can start a conversation. So if I'm hearing things that are not true, I follow those untruths up with questions as opposed to that's wrong. And I'm sure, like, again, you all are in this field, not because it pays well. Well, I mean, maybe I should move to West Virginia if it does, but because it's truly like a life passion, right? And so these conversations and you know how to have them. But with adolescents, it's even more important. So, okay, well, tell me more. Where'd you hear that? That's interesting. I haven't heard that before. That's also one that I like to say. And interestingly, condom use and preventative health are often viewed, or teenagers often think that other people are thinking about them, that they can't be trusted. Those other people are not actually thinking that, but teenagers live in a world where they assume that everybody else is thinking about them at all times. But it turns out that everybody else is thinking about themselves, thinking that other people are thinking about them at all times. So actually, you just have a bunch of teenagers walking around just thinking about themselves, and the other teenagers aren't really thinking about them so often. And I say that because they make it very complicated and they spin this web, and actually it's as easy as, no, they're not thinking that. And we know that they're not thinking that, and you can reassure them that actually we've never seen that to be the case, that if you're doing things to protect your health, that it wants to that they want to sleep around. Like that's the perception. That's not what we have ever seen play out in research. All right. So this is more for reference and is in there if you would like it. If your adolescent in front of you says, I don't need PrEP, I use condoms, and you can say, that's great. And in case there's an ever time, good. So we always like to applaud good decision making. So using condoms is an excellent decision. We want to make sure we're acknowledging that and also encourage them to think about other ways to keep themselves healthy. So I do like the I'm not at risk, because, and this kind of response is exactly like, this is kind of exactly what I say. Like, yeah, I hear you. Most people who get HIV didn't think that they were at risk either. Now that's not true for everyone, but you're in the space, right? Everybody that walks in was like, yeah, I sure was at risk. No, most people don't think that they are, or don't perceive the risk to be what it is. They might perceive a small risk, but not their actual risk. Okay. All right. So if we think back to Jordan, like, what you can do, and we've kind of already talked about this. I appreciate you being honest. When was your last HIV test? Let's get you tested today, along with some STI screening. I also want to tell you about PrEP, a medication that prevents HIV. So I will offer, and that is in line with guidelines. So here's what you've done by using the language that you see here on this slide. You've normalized it. You didn't challenge the magical thinking. You kind of leaned into it a little bit. You introduced PrEP as something that you do for everybody. Acknowledge the condom use is positive. So you're really kind of laying groundwork for future. And again, even if oh gosh, I just had two thoughts and even if they don't take you up on anything today, they have heard it, right? You have put it into the universe, and the next time they hear it, it won't be the first time. So that's the strategy that I like to use there. All right, and then Anthony, I often hear young people tell me their partners said that they're on PrEP, so I'm okay if we don't use condoms all the time. Yeah, and that's absolutely. And the reality is, oh, and you said the thing that I was going to say. We have to take care of ourselves, right? And this is why I tell young people, you are responsible for you. You don't know if that person, maybe they took PrEP last week. You don't know if they took it this week, right? You're not responsible for them, but you are responsible for you. So you need to do the things that are best available. So I just briefly wanted to say that on this slide in the lower left-hand corner, the current language on the CDC website is that PrEP is recommended in adolescent. Like, there's not much there. So the language has really changed what is on the CDC website. But the things that are on this slide these were things pulled prior to what's on there right now. And so the most important thing, inform all sexually active adults and adolescents about PrEP. And that was the change that happened about 4 years ago. I guess it kind of rolled out about 4 years ago, and it went from the risk, right? So we used to risk stratify and say, you're at risk, therefore you get to learn about PrEP and you get to learn about PrEP. You're really low risk, so you don't need to learn about PrEP. It turns out that adolescents especially go to the doctor about once a year if you're lucky. And so their risk category could change dramatically between the year that you see them, right? So this is one of the reasons we really push to have this conversation with everyone. And so the question is, why doesn't it happen? And I talked to my pediatric residents about this a lot. We've talked about the patient level barriers, but frankly, providers are worried about patient adherence, which isn't actually quite as big of a deal as we thought when PrEP was initially introduced, right? As long as you're taking 3 to 4, I don't tell teenagers this, I'm like, you need to take it every single day. And what I know is if they're hitting 4 to 5 days, they're pretty good. Like that's going to be pretty good, depending upon the type of sex that they're having. They're also worried about confidentiality for good reason. Physicians and providers are worried that they don't know enough about it. And then when they learn, that's all I have to do. They're like, oh, I had no idea. I thought it was complicated. I thought I had to monitor them all of the time. I thought they had to come back into clinic all of the time. And so we can dispel a lot of the myths to try to get PrEP into the hands of the frontline folks. So y'all are, and then you have a whole community of frontline folks who are seeing these adolescents. And they also are where we can do some really good prevention work. So my last couple of thoughts here are really about giving PrEP specifically to minors is that no state expressly prohibits minors access to PrEP. However, the laws vary dramatically, and they're also changing often. So in Texas, we joke that we're glad sometimes that the legislature only meets every other year for like 5 months, because if they met all of the time, we would have a lot of laws, but instead we don't have as many. But Idaho is a really good example of how nothing. So if someone's under the age of 18, they can't consent for any medical care. Any, unless it is like someone's been hit by a bus. So the absolute emergency can be like, sure, because I mean, they're probably not like anyway, but everything else. So a pregnancy test, an HIV test, a positive HIV test, these are all, none of it is confidential in Idaho. And we are seeing that in more and more states that legislation be introduced. So I don't want to go over the laws because they're going to change, right? In your state, in your area, they're going to change. You have to know what they are. And I wish that I could point you to a place, but literally every place I used to use, they're having trouble staying up to date because of how rapidly the laws are changing around minor consent. So what I will say is, you want to make sure that a young person understands how you can and can't maintain confidentiality. The worst thing in the world would be for them to expect it and not be able to get it. And this is the one thing that I really want to point out is explanation of benefits and billing documentation will often have information on there that shouldn't be shared, but you don't realize it. Then it comes through the EOB, and then parents are like, why did you get this HIV test? What is happening here, right? So you have to know kind of your flow of information for the confidentiality piece. So even if the provision of the test or the provision of care is confidential, the back end of it may not be. So again, it's so nuanced that I just encourage you to really know what's going on in your area. So we require parental consent under the age of 18, I assume for PrEP. And how would we address an adolescent's concern that my parent will now know that I'm sexually active? So this, Anthony, is what we're facing nationally in so many of the states. And I've actually brought this up in a number of different contexts recently. And that is the evidence-based, like the standard of care, best practice for adolescents is to give them this decision-making independently. That is not realistic in so many places now. So we have to strengthen our ability to be able to involve parents. And unless you think that it's going to be a direct harm, I actually encourage the conversation. And I will even go as far to say, I think we should have this conversation in clinic today. It kind of flies in the face of everything I've ever done in adolescent medicine. But I will say I think maybe we should have this conversation. I can bring it up and I can kind of start the conversation so you don't have to be the one to bring it up. What do you think about that? So I will, again, if I think that family is safe, that's the other thing that is hard to know if you don't have an established relationship. If you think that this kid could come into harm because the family has found out that they're sexually active, that's a completely different conversation. But if they're just, rightly concerned and they don't want someone to know, well, then I think that you can play a really important role in kind of discussing. And I do a lot of norming, like, so glad y'all came in. This is the age where we really start talking about keeping our bodies safe. And one of the spaces is around sexual activity. Lots of my patients, this is kind of the age by 12th grade, 50% of 12th graders have had sex. And so that is, and I like to say that's half, right? So half, and I realize that half and 50%, people need to hear it in multiple ways. So we talk about this, and we were having this conversation, and it sounds like this is one that we should have here. And so that has been fairly effective. I tell my residents all the time, most parents already have a clue that their kid is having sex. Like, they don't, not everybody knows, but a lot of them do. So having this conversation isn't necessarily going to be totally out of left field for most. As a, just looking at my time, I'm almost out of time. As a brief note, I do want to say that our PrEP options are very similar to what we have for adults, but the Descovy brand is not available for people under the age of 18. It's not approved. Everything else, though, is just the weight requirement. I don't know about y'all. I can't get lenacapavir, the twice yearly lenacapavir, to be stocked very easily around here, and the price is pretty prohibitive right now. But I am excited about that option, especially because it doesn't have some of the same pharmacokinetic problems that the cabotegravir, the every 2-month cabotegravir does. So I'm really optimistic about the future. This is what I was saying from the beginning, that I'm optimistic about where we are at this point in history with HIV prevention. And the lenacapavir, the long acting, I think is going to be life-changing for a lot of our adolescents and young people, because the adherence is no longer an issue, at least for those 6 months. So these are just some additional adherence challenges that for the most part are not different than adults. Though I will say that transportation is like an intersectional issue for adolescents too. So lots of our patients have transportation concerns to get to clinic, but adolescents, even if they had access to a car, some of them can't drive. They don't have licenses. So it's like multiple, not that all adults have licenses. There's just some additional adherence challenges for adolescents, including trying to do anything every day, right? I don't know if any of you have teenagers, trying to get them to brush their teeth every day or even take a shower, right? That can be a challenge. So getting them to remember medication can also really be a challenge. All right. And so this is my last slide. What are the support strategies that work for adolescents? And it's really, the centering teens. I would encourage you that if you are seeing adolescents and teens in your program, to invite one of them to review what you're doing. We're good at CABs, I think, in this space. We're not as good at YABs. So YABs are Young Adults Advisory Board. And so if you do want to see, and kind of outreach to maybe your 16, 17-year-olds, have a 16 or 17-year-old come in and see, is this youth friendly? Or am I no, I'm going to walk into your clinic and be like, I don't want to come back here. So you want to have that lens for what you're doing. Remember, you are putting things into the universe. So maybe the next time you build the trust, they come back and can listen or like be a little bit more open to it. The triadic communication, the teen, the parent, the provider is really critical in this new world of revision of confidentiality. And Samantha, yes, brushing the teeth, I swear. Like, do you not want better breath? But that doesn't usually motivate them. It's very interesting, the things that do and do not motivate teenagers. So you all can have, I mean, I assume that you have access to the slides if you would like. I'm happy to answer any other questions. I know that we're about 5 minutes before the end of the time. So thank you.
Thank you. We do have, we can allow a few minutes for a few questions if anybody has any.
I also like, I'm never, my feelings are never hurt if people don't have questions. Sometimes I just like to absorb information, so it's fine. I'm a new community health worker, but as a parent of teenagers, how do you seek this support? And Samantha, the support that you're talking about, do you mean just like adolescent friendly space? I don't know if you want to, if you're in a position to come off mute or just type in there. I want to try to answer the question that you have.